Respected faculty members and dear participants, today I'm going to deliver my lecture on ultrasonography of bovine abdomen. Uh, Before I discuss ultrasonography of bovine abdomen, it is very important to tell you that to understand this lecture, you must have basic knowledge of ultrasonography. And I hope that yesterday all of you attended the lecture delivered by Dr. Pankaj Gupta on basic ultrasonography. So, with that background, we'll move ahead today and discuss why and why ultrasonography of bovine abdomen is important and what are the normal and abnormal things which we should look while performing ultrasonography. So, first question arises: why the ultrasonography of bovine abdomen is important? As you all of you know that bovines with abdominal disorders, they exhibit variable and non-specific symptoms. The symptoms of bovine abdominal disorders are not very specific or pathognomonic for any disease. For example, in most of the diseases, the owner reports that the animal is animal is showing inaptitude or is anoretic. uh, the when we examine the animal clinically, we find reduced ruminal motility or reduced reticular motility. The feces may be diarrheic or they may be constipated. So they are all non-specific symptoms, and even hematobiochemical alterations are not very specific for any disease. The radiography, which is extensively used for diagnosis of diaphragmatic hernia and detection of metallic foreign bodies, is not applicable in most of other conditions. So its use is limited only for very few conditions. So far, about 2 to 3 decades ago, till 2 to 3 decades ago, exploratory laparotomy used to be the gold standard in case of abdominal diseases of bovine. For each and every condition, suspected condition, we used to perform, or it was recommended that you perform exploratory laparotomy, and after that you diagnose the condition. You may treat that condition through the same incision which you have used for exploratory laparotomy, or you may perform another surgery on the other side of the abdomen to treat the condition. So animal in many conditions used to be subjected to two surgeries, and this was time consuming, and at many a times after performing exploratory laparotomy, it used to be known that the condition from which the animal is suffering is not curable. So in that case, it used to be a waste when we consider the perspective of the owner, because the owner spends time and money as well, and he loses his animal also in case of such conditions. So nowadays, the owners want the diagnosis and prognosis before surgery. They even want some type of guarantee or assurance that their animal is likely to survive after performing surgery. So how to give that assurance to the animal? This assurance can be given to the animal if we can diagnose the condition accurately before conducting any surgery. For that, the ultrasonography is very handy and very helpful, because ultrasonography is a non-invasive procedure diagnostic tool. It is useful in evaluating gastrointestinal motility, which otherwise required fluoroscopy and which was not usually available to the veterinarians. In addition to the gastrointestinal motility, it can detect position of abdominal organs, the intestinal distension, peritoneal fluid of any type, fibrinous adhesions, etc. And it is very simple to perform. It is performed on non-sedated animals, because if you perform it on sedated animals, the motility of GI tract may be reduced. So it is recommended that it should be performed on non-sedated animals, and the cost involved is only the initial cost, that is investment of purchasing a ultrasound machine. Later on, the recurring cost is minimal. It only costs on the it involves the cost of uh, ultrasound paper and the ultrasonographic coupling gel. So the recurring cost is minimal. Now, what are the organs which can be scanned in case of bovines by using ultrasonography? See, some organs can be scanned from the left side of the abdomen and some organs can be scanned from the right side of the abdomen. Normally on the left side, we scan reticulum, spleen, rumen, abomasum, and urinary bladder in case of cows. And on the right side, again, we examine the reticulum, omasum, abomasum, liver, small intestines, large intestines, and right kidney. For examination of left kidney, urinary bladder, and the other areas of the pelvic cavity, we require transrectal ultrasonography in case of adult animals. And for examining the uterus and ovaries, we can perform perrectal ultrasonography or transabdominal ultrasonography. So either transrectal or transabdominal ultrasonography is required for scanning abdominal organs in case of bovines. Now the question arises, which type of transducer is suitable for scanning bovine abdomen? See, for routine use, we can use 3.5 megahertz transducer because it provides adequate depth and good resolution. But this is not fixed. You can use 5 megahertz transducer or even higher frequency transducers for examining superficial structures like liver, spleen, sometimes even intestines. The general rule of ultrasonography is that higher the frequency, better is the resolution, but the depth of penetration decreases, and vice versa. That means if you are using higher frequency transducers, you will be able to scan superficial organs with better resolution. For scanning deeper organs, you require lesser frequency. However, the resolution is not as good as with higher frequency transducers. You can use any type of transducer, a linear, a curvilinear, a microconvex transducer, any type of transducer which you have can be used. Although the sector scanner with smaller footprint is better to scan when it comes to scanning through intercostal spaces. Because it has smaller footprint, it can better scan the abdominal organs through intercostal spaces. Before performing ultrasonography, the hair clipping and use of depilatory cream or shaving is important, and application of coupling gel is important to establish close contact between the transducer and the skin so that air is not in between these two surfaces, because air acts as impediment to the transmission of ultrasound. Now just a quick look at the organs, topography of organs from the left side and from the right side of the bovine abdomen. See, on the left side, you can see the reticulum, which is roughly located between 5th, 6th, and 7th intercostal spaces. The spleen, it is located between 7th to 12th intercostal space and has an oblique position. The rumen occupies the remaining of the left side abdomen, and spleen is between the abdominal wall and the rumen. At the ventral part of the abdomen, just caudal to the xiphoid, there lies the abomasum. Now, similarly, on the right side, the reticulum position of the reticulum is same between 5th to 7th intercostal spaces. Behind that, on the ventral abdomen, is the abomasum, which lies immediately caudal to the xiphoid cartilage, and on the lateral side is the omasum, which lies between about 6th to 11th intercostal spaces. The liver, which is very superficial and adjacent to the right abdominal wall, it lies between the caudal, between the 12th intercostal space and extends up to 7th intercostal space. The cecum, which occupies the middle portion of the abdomen or just below the end of lumbar fossa. Above or dorsal to the cecum lies the proximal loop of the colon, and dorsal to the proximal loop of colon lies the descending duodenum. Remaining abdomen is occupied by the loops of jejunum and ileum. So these are the structures which can be scanned from the right side of the abdomen. Now this is just rough diagram showing you the areas where different organs can be scanned. So this is the area for scanning the reticulum from the left side. Behind or caudal to the reticulum is the area for abomasum. This is the area for spleen, and rest of the remaining abdomen on the left side is occupied by rumen. In cases of left displacement of abomasum, this area, red area, is occupied by the abomasum. This is not normally, abomasum is not normally seen here, but in case of left displacement of abomasum, the abomasum can be detected here. Similarly, on the right side, the area of reticulum, and caudal to the reticulum on the floor of abdomen is the abomasum. On the lateral side is the omasum. This is the liver. The jejunum and ileum, which occupy main portion of the abdomen, ventral abdomen. The cecum, dorsal to the cecum, is proximal loop of colon, proximal colon, and proximal to the dorsal to the colon is descending duodenum, and highest in the paralumbar fossa, close to the last rib, is right kidney. So these are the structures which can be scanned. These are the areas from where these structures can be scanned. Now we'll take organ-wise scanning, starting from the reticulum. The why we should scan reticulum and where to scan the reticulum. See, for scanning reticulum, we require evaluation of the contour and motility of the reticulum. We want to see the surface of the reticulum and its motility, the pattern of motility, that is the frequency as well as the strength of reticular motility, and it's a relation to adjacent structures, adjacent organs like spleen, diaphragm, omasum, abomasum, and liver. Also, we can visualize the lesions caused by traumatic reticuloperitonitis and the lesions caused by traumatic reticuloperitonitis, which can be detected by ultrasonography, or abnormal reticular motility, fibrinous adhesions between reticulum and adjacent organs, and effusions. Similarly, we can detect reticular abscesses and also perform ultrasound guided percutaneous drainage of some of the reticular abscesses. Why some of the reticular abscesses? Because only those abscesses which are very close to the abdominal wall and are in fixed position, they can be lanced or drained percutaneously under ultrasound guidance. Similarly, we can also diagnose diaphragmatic hernia. As today morning Dr. Chaudhary was saying, that ultrasonography is one of the better modalities for diagnosing diaphragmatic hernia in cases where there are certain opacities in thoracic cavity like hydrothorax or cysts or tubes, where you cannot clearly say on radiography whether this radio opacity is because of herniated reticulum or because of some other reason. So there ultrasonography plays a very important role. Where to scan the reticulum? Reticulum is usually scanned on the ventral and lateral aspect of the thorax on both sides of the sternum up to the level of elbows. So what is the site? It is usually 5th, 6th, and 7th intercostal spaces in case of normal animals. What are the normal findings? What we find on normal ultrasonographic scanning of the reticulum? The normal reticulum appears as half moon shaped structure with an even contour. It lies immediately adjacent to the diaphragm and ventral abdominal wall. However, layers of the reticulum and the honeycomb mucosa, they usually are not visualized. In some cases, the different layers of reticular wall can be seen as in cases of peritoneal effusion, and when they are seen, they will be visible as echogenic layers of serosa and mucosa, and the muscularis will appear as an hypoechoic line in between the echogenic lines of serosa and mucosa. We can also observe biphasic contraction of the reticulum, which usually is 1 per minute or even more. And these biphasic contraction, we see two types of contraction. The first contraction is incomplete, which is followed by complete contraction, or the primary contraction of the reticulum. The limitation of ultrasonography while scanning the reticulum is that reticular contents, presence of foreign bodies, whether metallic or non-metallic, and opposite reticular wall cannot be scanned because of the presence of gas and ingesta. They do not allow the penetration of ultrasound deeper beyond the near wall of the reticulum. So in this video, you see the reticular motility. This motility is because of the respiratory movements. However, this is the first contraction, primary, and this is second contraction. Look at this video again and see the contractions of the reticulum. There will be two contractions. One will be incomplete and second will be complete. During second contraction, the reticulum will disappear from the screen. You will see the B mode as well as the M mode. Please have a look again. This is first contraction and this is second contraction when reticulum disappears. Now, what are the abnormal conditions that can be diagnosed? Abnormal conditions of reticulum. The first, as I told, is traumatic reticuloperitonitis. So what will be the findings in traumatic reticuloperitonitis? The reticular wall, which normally appears as smooth, crescent shaped, will appear undulating due to the deposition of fibrinous material between the reticular wall and diaphragm, and between the reticular wall and the abdominal wall. The reticular motility will be altered, both in terms of frequency as well as amplitude. Frequency of reticular contractions may be normal, it may be reduced, or it may be totally absent. The amplitude of reticular contraction is either reduced or it is completely indistinct, not detectable. The distance between abdominal wall and reticulum might be increased, or distance between the diaphragm and reticular wall will be increased because of fibrinous adhesions, fibrinous deposits between the reticular wall and the surrounding areas. So this is, I'll show you a video in which you will find that reticular wall is at a larger distance away from the abdominal wall and diaphragm, and there are fibrinous adhesions as well as effusion. You will find the fluid. See, this is the reticular wall. It is undulating. It is not smooth as in case of normal cases. These are the fibrinous deposits, and the anechoic black areas. Anechoic black areas are the effusion or fluid. You can see the distance between abdominal wall and the reticular wall is increased. The reticular wall is not smooth, it is undulating. These are the fibrinous material deposits, and these are the anechoic areas representing fluid. So these are the findings in case of traumatic reticuloperitonitis. Now, next condition that is important in case of reticulum is perireticular abscess. The reticular abscesses have echogenic capsule, which is surrounding a homogeneous hypoechogenic to moderately echogenic center. This reticular abscess can have variable appearance. The echogenic capsule thickness can vary, its ecogenicity can vary, and similarly the purulent material which is within the ecogenic capsule will also have different appearance, ranging from uh, hypoechoic to moderately ecogenic. It may vary in diameter. The abscesses can be very small, ranging only from few centimeters to very large, up to 15 centimeters. Because of the presence of abscess, the distance between abdominal wall and reticulum will be increased. Reticular motility, as in case of peritonitis, traumatic reticular peritonitis, reticular motility will be altered. The motility may be increased, reduced, or absent, and pattern of biphasic contraction is often maintained but usually weak or indistinct. So this is the findings in case of perireticular abscesses will be almost similar to the findings in case of traumatic reticuloperitonitis, except that in addition you will find the reticular abscess. Then once the ultrasonographically you diagnose the abscess, and if it is within approach, it can be drained by using ultrasonographic guidance through percutaneous lensing. But this is possible only in those cases where the abscess is in direct contact with the abdomen and is in comparatively fixed position. So in this video you will see an abscess between the abdominal wall and the reticulum. The abscess has a capsule and central anechoic area representing fluid content, and the distance between abdominal wall and the reticulum is increased. See, this is the reticular wall, this is the abscess which has fluid content, and you note the motility of the reticulum also will not be as in case of normal reticulum. So although the contractions are there, they are not typical biphasic contractions. The frequency as well as their strength of contraction is both altered. Now, third reticular condition is diaphragmatic hernia. Dr. Chaudhary elaborated in the morning how ultrasonography is important in diagnosing diaphragmatic hernia. The normal reticulum is seen between 5th, 6th, and 7th intercostal spaces. There is some difference between bovine, that is white cattle, and the buffaloes. In case of white cattle, if you see the reticulum in 5th intercostal space, whether the animal is pregnant or it is non-pregnant, it is normal. And in case of buffaloes, in case of advanced pregnancy, or if there is abdominal distension due to any reason, for example, in case of acute bloat, you may see the reticulum in 5th intercostal space. In that case, it will be normal. However, if you see the reticulum in 5th intercostal space in non-pregnant buffaloes, you can suspect diaphragmatic hernia. Similarly, in case of cattle, as well as in case of buffaloes, if you see the reticulum in 4th intercostal space, if you see the reticulum in 4th intercostal space, that will mean that the reticulum is in the thoracic cavity, and that can confirm your diagnosis of diaphragmatic hernia. The reticular motility is often decreased or not detected in case of diaphragmatic hernia, because there will be adhesions between the diaphragm, between the abdominal wall and reticulum. So the motility, either it is not detected or it will be decreased. Now, next organ is the omasum. The omasum, why it should be scanned? It can be scanned for detecting omasal impaction, reticulo-omasal stenosis, abomasal displacement, or volvulus. But let me tell you that the changes observed in case of omasal affections are not as characteristic as they are in case of reticular affections. So there is very slight variation between the normal omasum and diseased omasum. Where should the omesum be scanned? Omesum is normally scanned between 6th and 11th intercostal spaces on the right side. And it is easily identified because of its location, which is immediately adjacent to the costal part of the abdominal wall. How does it appear on ultrasonography? Uh, all hollow organs, may it be reticulum, omesum, abomesum, rumen, all they appear as semicircular or crescent shaped echogenic lines. And beyond that, very rarely you find other structures. Otherwise, nothing is visible beyond that because of the presence of gas and ingesta, except in case of abomesum, where you can see the ingesta as heterogeneous echogenic material. In case of omesum, abomesum, omesum, reticulum, and rumen, you find only an echogenic line, which is semicircular in shape. The omesum is located close to the right abdominal wall in 8th and 9th intercostal spaces, and its size varies depending upon which intercostal space you are scanning it. The greatest size will be observed in 9th intercostal space. And unlike reticulum, omesum normally does not have motility of its own. If you observe the motility of, sometimes you observe churning motility. Other than that, if you observe the motility of abomesum, you suspect some disease condition. The omesal lamellae, as you know, the omesum has leaf-like mucosal folds within the lumen. They are usually not imaged in healthy cows because of intraluminal gas. Occasionally, only the attachment of omesal laminae will be seen as echogenic cone-shaped structures. They will be protruding from the inner surface of the omesum. These are the pictures showing the ultrasonogram of omesum. The pictures have been recorded at 8th intercostal space. And here you can see this is the semicircular echogenic line, which is thick echogenic line. This represents the near wall of the omesum. Beyond that, nothing is visible because of the presence of ingesta and gas. And there is a part of liver in between the abdominal wall and the omesum. Both the pictures are through the 8 intercostal space, but in this picture, you don't find the liver between the abdominal wall and the omesum, whereas in this picture there is liver. So it depends upon the actual site from where you are scanning the organ. When you scan it dorsally in the intercostal space, you will find liver will be overlapping the omesum. Whereas if you scan from slightly ventral region in the intercostal space, the liver will not be between the abdominal wall and the omesum. So omesum will be in direct contact with the abdominal wall. So what are the abnormal conditions or abnormal findings in case of omesum? One is the omesal impaction. As in the beginning itself, I told you that the changes in diseased omesum and healthy omesum are not very characteristic. So it is very difficult to diagnose conditions based on ultrasonography alone. However, it can definitely help in assisting the diagnosis. In case of omesal impaction, the omesum will be enlarged and it occupies more than 6 intercostal spaces. Normal omesum location is between 6th and 11th intercostal space. So if it occupies more than 6 intercostal spaces, that definitely gives an indication of omesal impaction. In case of reticulo-omesal stenosis, the contents of the reticulum do not pass freely into the omesum. So omesum will be smaller in size, and in such cases, omesal motility can be observed. So if you observe omesal motility, as I told you, omesum does not have motility like reticulum. But however, if sometimes you observe the motility, you must suspect some disease condition, and this is one disease condition, that is reticulo-omesal stenosis, in which you will find omesal motility. Similarly, in case of abomesal reflex, you will be able to see omesal lamellae as thin echogenic lines running parallel to one another due to increased fluid content in the omesum. Normally, the omesal laminae are not visible, or even if at all they are visible, they will be visible as cone-shaped structures from the inner surface of the omesum. However, if you find echogenic lines running parallel to one another, they will indicate increased fluid content in the omesum, which is usually because of abomesal reflux. Now, coming to abomesum, what are the indications? Why should we scan abomesal area? We can scan abomesum for suspected conditions of abomesal displacement, abomesal volvulus, and for performing ultrasound guided percutaneous abomesocentesis. Abomesocentesis is performed to detect the pH of the abomesal contents, to detect blood in abomesal contents, because a presence of blood indicates may indicate ulcers. So, which is the site for scanning the abomesum? Abomesum is scanned caudal to the xiphoid and both in right as well as left paramedian region, just caudal to the reticulum. It is frequently scanned between caudodorsal blind sac of rumen and ventral abdominal wall, immediately caudal to the reticulum in the post-xiphoid region. What are the normal findings in case of abomesum? In case of abomesum, either you will not detect its wall, or it will be visible as very thin, narrow echogenic line. Unlike other organs like reticulum, omesum, and rumen, where you find thick semilunar or crescent shaped echogenic wall, in case of abomesum, you will not find that. Instead, you will find a structure like this, which has heterogeneous echogenic appearance, and this represents the ingesta of the abomesum. So again, just like abomesum, just like omesal scanning, in abomesal scanning also, if you scan from the ventral line, you'll find this type of appearance where only the abomesum is being scanned. But if you scan from the paramedian line, either left or right, on the right side, you will find this is the omesum, and this is the abomesum, and this is omesum. Similarly, if you scan on the left side, you will find the abomesum and the rumen. So this is the appearance of abomesum. You can clearly see the difference between the appearance of abomesum and omesum. Omesum appears only as a semicircular or crescent shaped thick echogenic line beyond which nothing is visible, whereas entire content of the abomesum is visible as echogenic structure. So what would be the abnormal findings in case of abomesum? See, the most common abnormalities of abomesum, which can be detected ultrasonography, or displacement of abomesum. As you know, displacement can be left displacement as well as right displacement. When there is left displacement, the abomesum displaces to the left side, and it occupies a position adjacent to the left abdominal wall between the rumen and the abdominal wall. So you scan last three intercostal spaces on the left side from ventrally to the dorsally. What happens? Ventrally the rumen will be in contact with the abdominal wall. So first of all, you will detect the ruminal wall, which will appear as thick echogenic line, and as you move dorsally, the distance between the rumen and the abdominal wall will go on increasing, and suddenly the ruminal wall will disappear and abomesum will make its appearance. When you still go proximally, only the abomesum will be seen, rumen will not be visible, and when you go still dorsally, the abomesum will disappear and rumen will appear again. So that is the finding which assists you in confirming the left displacement of abomasum, that abomasum is scanned between the abdominal wall and rumen in last three intercostal spaces on the left side. Similarly, on if there is right abomasal displacement or abomasal volvulus, the abomasum will occupy the space between the right abdominal wall and the other structures on the right side are liver, omasum, intestines, the cecum, colon. So abomasum will occupy the space between the abdominal wall and those structures. Therefore, uh, immediately under the abdominal wall, you will be able to scan the abomasum and the other structures which are normally visible at their locations like liver, omasum, small intestine, large intestine. They will be displaced. Either they will be displaced and frequently they will not be scanned, or they will be completely out of the scannable area of the right abdomen. So that will confirm the right abomasal displacement. However, you cannot distinguish between right abomasal displacement and volvulus based on ultrasonography because both the conditions will give same ultrasonographic picture. Now coming to small intestines, which are also scanned from the right side. All these structures which we have been discussing till now, they are scanned from the right abdominal wall. The small intestines, why they should be scanned? They are scanned to detect ileus. Ileus is a condition where you find that the intestines are distended, they are amotile, and this ileus can represent a number of disease conditions. So you detect ileus by ultrasonography, and the area where you should look for small intestines is from 6 intercostal space to tuber coccyx, and from transverse process, that means entire right side of the abdomen except the areas for abomasum, omasum and reticulum, from transverse process of lumbar vertebrae to the linea alba on the right side. What are the normal findings? The normal findings are that descending duodenum can be imaged from 10th intercostal space just close to the gallbladder, and it can be traced back towards the tuber coccyx in a horizontal line. Its diameter ranges from 1.5 to 4 centimeters, and it will be enclosed in the serosal lamellae of omentum. The jejunum and ileum cannot be differentiated from one another. Multiple loops of jejunum and ileum will be seen throughout throughout the right flank as well as the ventral abdomen from the right side, and there will be multiple loops in one scan. The loops will be hypermotile. You cannot focus upon one particular loop to carry out this study in real time sonography. You will have to freeze the image to study that loop. Otherwise, the motility will be so strong that they will be changing their shape and size and disappearing from the screen very rapidly. However, because of the lack of gas in case of bovine small intestine, the contents and entire wall of small intestine can be easily evaluated. So for other hollow organs except abomasum, we have seen that we can see only the near wall of the organ, that is that of omasum, reticulum and rumen. But in case of the intestines, small intestines, because of the lack of gas, the ultrasound penetrates deeper through the intestinal contents, and we can examine the entire wall as well as lumen of the small intestines. So in this video, you will see the motility of small intestines. You will find that there are multiple loops, but you cannot keep focused on one particular loop because they will be disappearing and changing their shape so rapidly that it will not be possible to study them in detail. And there will be more than 10 loops in one scan. But wherever the loop is seen, you can see that the entire lumen is visible. See it again. These are the normal intestinal loops. There are multiple, numerous loops, which here the position of transducer is not being changed, but still you can see that the loops are disappearing because of the motility of small intestines. At some places you find the reverberations because of some gas. Now, what are the abnormal findings in case of small intestine? The abnormal finding is ileus. So how to detect ileus? Ileus is obstruction of small intestine that may be functional or that may be mechanical, and proximal to the ileus, the intestinal loops will distend, they will be amotile, and there will be peritoneal effusion. There will be effusion of the fluid in the peritoneal cavity. So all these uh, things can be detected on ultrasonography. That proximal loops in case of ileus will be extremely dilated. They will be dilated to more than 3.5 centimeter in diameter. Normal diameter of small intestine ranges from 1.5 to 4 centimeters. The loops will be amotile. There will not be any motility. Although you can detect passive movement of contents, you can see gushing movement of contents from within the loops of the intestines. Loops will be visible as cross section. In cross section, they will appear as round or oval in shape, as well as they can also appear as longitudinal sections on the scan. And there will be very few loops visible in one scan, unlike normal small intestine. You will see only one, two, or at the maximum 5 or 6 loops in a scan. When you see very few loops, 1 or 2 loops, that indicates proximal jejunal or duodenal ileus. However, when you see more than 5 loops in one scan, which are distended and amotile, you can suspect that this is the obstruction or ileus of jejunum or ileum. In general, larger the diameter, more proximal will be the ileus. But this does not hold true always, because longer longer the condition persists, the larger will be the diameter of intestinal loops. Intussusception. Intussusception is actually uh, a form of ileus. It causes ileus. So all the conditions which I discussed in previous slide, they will be detected in case of intussusception. That is, you will see distended intestinal loops which are amotile. There will be passive movement of ingesta within the loops of intestine, and there will be anechoic fluid in between the intestinal loops. So that only indicates ileus. That does not diagnose or help you in diagnosis of intussusception. So how intussusception is diagnosed? If you find typical pattern of bull's eye pattern, or that is called target lesion, or that is called onion ring type mass in case of cross section of the intussusception of intestines, or multiple layered mass of varying echogenicities in case of longitudinal section of intussusception. If you find any of these two patterns, that will confirm the intussusception. Otherwise, the earlier findings of distended intestinal loops, passive motility of ingesta, amotile loops, presence of anechoic fluid between the loops will only indicate ileus. However, this typical pattern of intussusception is not detected by transabdominal ultrasonography in most of the cases, because the intussusception, the portion of intestines involved in intussusception may not be within the reach of ultrasonographic penetration. So in most of the cases, if you can palpate the intussusception per rectally, that mass can be brought to the flank area and then it can be scanned. In those cases, you will find these patterns. Otherwise, the findings will only point towards the ileus. The exact cause of intussusception will not, exact cause of ileus will not be known. But as Dr. Chaudhary was telling in the morning that in Haryana or Hisar, they get hundreds of cases of diaphragmatic hernia, and he says that in other areas there also might be similar incidence of diaphragmatic hernia, but they go undiagnosed. Same is true with the intussusception also. In Jammu, we get hundreds of cases of intussusception every year, and whenever we find the ultrasonographic findings of ileus, irrespective of whether we find the typical pattern of bullseye pattern or multiple layers, we confirm it as intussusception, and in 99.9% or even 100% cases, it turns out to be intussusception. However, the other causes of ileus could be fecolids, compression of small intestine by space occupying lesions, which are difficult to detect because they may not be within the reach of ultrasound beam, and general peritonitis with fibrinous adhesions of small intestine, which can be very easily diagnosed by using ultrasonography. So this is varied picture of intestinal loops which are seen in ileus, and these have been found to be intussusception in our area. So all these pictures, although they represent only ileus, but they turned out to be intussusception in Jammu. See, in this case, you can see the lumen of the intestines. It contains hypoechoic material, so the wall of the intestine appears hyperechoic. In these cases, you see the contents are hyperechoic when compared with this picture. So the wall is not that clearly visible because the echogenicity of the wall and echogenicity of the contents is same in these pictures. You can see variable amounts of anechoic fluid in between the intestines. In all these pictures, you see only 4 to 5 or at the most 6 intestinal loops are visible, which are unlike the normal intestinal loops, which are visible more than 10 in one scan. And these are all the cross sections of intestinal loops, distended intestinal loops, and here you can see the transverse section of intestinal loop. These are the uh, cross sections, and this is the transverse section. Here you can see the quantity of fluid is too much in case of this slide. These are the typical patterns of intussusception, which I told you normally are not detected when you perform trans-abdominal ultrasonography. It is very rare that you will detect these patterns if the intussusception mass is very close to the abdominal wall. Otherwise, in just to just for your academic purpose or just for your satisfaction, you can palpate the intussusception rectally in those cases in which it can be palpated, as in case of non-pregnant animals. You can bring them close to the flank and then you can scan them trans-abdominally. And this will be the pattern. This is the upper two slides, upper two pictures. They show you the bull's eye pattern or target lesion. But here also you can see that the picture varies. In one case, the central lumen is hypoechoic, or you can say anechoic, whereas in another picture, the lumen is hyperechoic. So picture will vary from case to case, depending upon the degree of intussusception, how long it has been there, whether there is blood in the center of the lumen of the intestine. And this is the uh, scan showing the longitudinal section of intussusception, where you see multiple layers of intestine. Normally, a single intussusception will have 6 layers of intestine, but they cannot be detected in case of bovines clearly as you detect them in case of small animals. However, multiple detection of multiple layers of intestine like this will confirm that it is intussusception. Now, In case of intussusception, if it is long standing or if involves ileum and jejunum, you scan the abdomen from right side in any region. It may be flank, paralumbar fossa, it may be ventral abdomen close to the flank, it may be cranial abdomen close to the costal arch. Everywhere you find this type of picture, that there are distended intestinal loops, the anechoic fluid in between the loops. See, earlier I scanned in the paralumbar fossa, now I'm scanning close to the flank, fold of the flank. Since this is dependent part, you will find more fluid here, more fluid and distended intestinal loops. These loops are not changing their shape as they were changing in normal intestine, and there are very few loops in one scan. See, this is cranial abdomen close to the costal arch. Again, the same picture. This is transverse section. These are the cross sections. And wherever you scan, it may be 12th intercostal space, 11th, 10th, 9th intercostal space, you will find this type of picture in case of obstruction or intussusception or ileus involving the ileum or jejunum. However, if there is ileus of duodenum, you will find only loops, and they will be close to the costal arch in the 10th intercostal space or 11th or 12th intercostal space. Now coming to the large intestine, the cecum and colon, since they contain lot of gas because of fermentation of the carbohydrates, the ultrasonography is difficult. Here again, you only can detect the near wall of these organs as semilunar or semicircular hyperechoic thick wall. Other structures, deeper ingesta or the opposite wall cannot be scanned. The condition that can be diagnosed is cecal dilatation, and site for scanning large intestines is from the right flank medial to the descending duodenum. Descending duodenum, I told you, this is visible uh, from 10th intercostal space backward towards the tubercocci and follows a horizontal path. Ventral to that, you can scan the cecum as well as proximal loop of the colon. The spiral and descending colon are imaged dorsal to cecum, and they can be followed to lost rib by moving transducer horizontally. Large intestine is easy to differentiate from small intestine because it contains a lot of gas. Small intestine does not contain gas, so you can see the entire loop and entire wall of the small intestine, whereas in case of large animal, in case of large intestine, you can see only the near wall as curved echogenic thick line. And the motility of large intestine is not as prominent and frequent as in case of small intestines. However, differentiation of various parts of large intestine is difficult based on ultrasonography alone. The proximal loop of large colon and cecum appear as thick semicircular echogenic lines in the paralumbar fossa or just ventral to the paralumbar fossa. And spiral loop of colon appears like a garland with several echogenic arched lines next to each other. This is the scan showing you the cecum, which has been scanned from the mid abdomen just below the paralumbar fossa. Here you can see the cecum is in contact with the abdominal wall. This is the abdominal wall. This is the cecal wall. Again, semicircular line as in case of omesum or reticulum, and nothing is visible beyond that. In case of cecal dilatation, the only finding that you detect ultrasonographically is that the cecum and the proximal colon, they will occupy entire right side of the abdomen. They will displace all other organs and they will occupy the right side of the abdomen. Now, how to differentiate between cecal dilatation and between right abomasal displacement? These two can be detected by performing ultrasound guided aspiration or synthesis and checking their pH. In case of the abomasal displacement, the pH will be between 1 to 4. It is highly acidic. Liver, what can be seen in the liver, or what are the indications? To determine the position and size of liver and its vessels, diffuse and focal changes in the liver can be detected, like in case of hepatic lipidosis, abscesses, tumors, calcified bile ducts, and cholestasis. We can also diagnose thrombosis of caudal vena cava and perform percutaneous ultrasound guided synthesis or obtain biopsy of the liver for histological, cytological, or bacteriological examination. The site for scanning liver is starting at 12th intercostal space on the right abdomen and moving cranially to 7th intercostal space. How does liver appear on ultrasonography? The liver parenchyma appears as weak, coarse echos. They are rough echos distributed homogeneously over the entire liver area. The distance between the dorsal margin of the liver and the dorsal midline is shorter in 12th intercostal space than in 11th and 10th intercostal space. Same is true with the ventral margin of the liver and dorsal midline. It is shorter in 12th intercostal space than in 11th or 10th intercostal space. That means liver also occupies somewhat oblique position. It is closest to the dorsal midline in 12th intercostal space than in 11th or 10th intercostal space. Moreover, the area or the width of the liver is smaller in case of 12th intercostal space than in 11th or 10th intercostal space. And cranial to 10th intercostal space, liver becomes progressively smaller because of superimposition of the lungs. That means the widest area where the liver can be scanned is between 10th followed by 11th intercostal space. What you see in the liver, in addition to the hepatic parenchyma, you can see the caudal vena cava, the portal vein, and the gallbladder. The caudal vena cava always appears as triangular, as in this picture. It appears as triangular, and the vena cava, the portal vein appears as oval or circular, which has stellate ramifications. The caudal vena cava is always dorsal. You can see this is dorsal and this is ventral. This is towards dorsal side, and it is more deeper, that is medial, when compared with the portal vein, which is more lateral and more ventral when compared with the caudal vena cava. The caudal vena cava will have almost fixed size, whether you scan it through 12th intercostal space, 11th intercostal space, and in some cases through 10th intercostal space. Its size does not vary significantly, whereas the size of portal vein will vary from one intercostal space to the other intercostal space. And how you detect the thrombosis of caudal vena cava, or uh, if there is increased pressure in the caudal vena cava distension, this triangular shape of caudal vena cava will change to oval or circular if there is any obstruction in the caudal vena cava. Here you can see this is the portal vein, which has oval or circular shape with its stellate ramifications. This you can see the difference between using 3.5 megahertz transducer in this picture, as well as in this picture. The transducer that has been used is of 3.5 megahertz frequency, which scans deeper. Here you can see this is the omasal wall, and this is the liver. Whereas in this case, the scanner used is of 6.4 megahertz frequency, so it has scanned not too deep as compared to that picture. Again, you can see the caudal vena cava, it is triangular. This is portal vein, which is oval, and you can also see the wall of omesum, which is situated medial to the liver. What are the abnormal findings in case of liver? One is hepatic lipidosis or the fatty infiltration. This results in ultrasonography findings in case of this condition are the liver size will be increased, there will be rounding of liver margins, the coarseness of echos will increase. Already the liver echo texture is coarse, but it will become more coarser when compared with normal liver. The echogenicity of liver parenchyma will be increased close to the abdominal wall. It will be hyperechoic than normal, close to the abdominal wall, whereas the deeper parenchyma of the liver will be lesser echoic. It will be hypoechoic. And the reason for that is the fatty infiltration increases the echogenicity of the liver. But as the echogenicity increases, more ultrasound is reflected back from the superficial parenchyma of the liver, so that only few ultrasound reaches the deeper part, which appears as hypoechoic. And blood vessels will not be visible, or they will be poorly visible. These are the characteristic findings in case of hepatic lipidosis. In case of another condition that can be diagnosed is liver abscesses. They appear as circumscribed lesions within the liver. As in case of reticular abscesses, they have variable appearance. They have thick echogenic capsule, which contains a center which is homogeneously, maybe homogeneously hypoechoic, or it may be uh, hyperechoic. So the picture of abscess will vary on ultrasonography depending upon the contents of the abscess, and sometimes it becomes difficult to detect or differentiate the differentiate the conditions like tumors, abscesses, because they may give similar picture. So in those cases, the ultrasound guided uh, aspiration for cytology or ultrasound guided biopsy will be required for confirmatory diagnosis. Ultrasonography can also distinguish between hepatocellular cholestasis and obstructive cholestasis. In case of hepatocellular cholestasis, the characteristic changes will be fatty liver, as I have discussed earlier, and liver congestion, or there may be uncharacteristic changes. The bile ducts, however, the bile ducts will not be enlarged, or they will not be dilated in case of hepatocellular cholestasis. Whereas in case of any obstructive cholestasis, the bile ducts will be dilated. So by using ultrasonography, you can reliably distinguish between hepatocellular cholestasis and obstructive cholestasis. Other abnormal condition is if you find any thickening of the gallbladder wall, or you find abnormal gallbladder contents. Normally, gallbladder contains only anechoic fluid that appears completely black. If you find any sediment in the gallbladder or any concretion in the gallbladder, or if you find thickening of the gallbladder wall, that will indicate a disease. Now coming to the left side, the first organ, you can also scan the reticulum from the left side. The site is same as on the right side, that is fifth, sixth, seventh intercostal spaces. And if you find the reticulum in fourth intercostal space in case of cattle, it is DH. If you find uh, reticulum in fifth intercostal space in case of non-pregnant buffalo, you can assume it is DH. If you find it in fourth intercostal space, it is definitely DH. You can also scan abomasum from the left side, left paramedian side, just caudal to the zephyd cartilage. So those structures I have discussed on the right side. So you can scan them on the left side also. So coming to the spleen is scanned between 7th and 12th intercostal spaces on the left side. Why it is scanned? There are no definite indications for scanning spleen in the case of cattle. However, while performing ultrasonography, you may come across some diffuse enlargement of the spleen, that is splenomegaly, or you may find some focal lesions which may represent tumors, abscesses, or uh, hematoma. So those can be the findings on scanning the spleen. However, to distinguish between different causes of disease conditions which cause splenomegaly or which cause focal lesions in the spleen is very difficult, and that requires aspiration or biopsy for histopathological changes. You can see that in these pictures, this is the spleen, and medial to the spleen or ventral to the spleen, you find the dorsal sac of the rumen. The dorsal sac of the rumen, you can see it is curved, homogeneous or smooth line in case of this picture. It is almost flattened in case of this picture. And the appearance of this different shape of the ruminal wall will depend upon the contraction of the rumen, whether it is in relaxed state or it is contracting or it has contracted. The spleen in seventh and eighth intercostal space is predominantly between reticulum and abdominal wall, and in ninth to 12th intercostal space, it is predominantly between rumen and abdominal wall. As you all know, the visceral surface of the spleen lies against reticulum and rumen, whereas parietal surface is in contact with the diaphragm. The dorsal part is superimposed by lung and may not be imaged, and spleen follows an oblique path. Oblique. It is obliquely placed in the abdominal cavity, or you can say it is placed from caudodorsal to cranioventral direction. How does spleen appear? The parenchyma has uniform, weak, fine, and dense ecotexture. When you compare the splenic ecotexture with uh, the liver has coarse ecotexture, whereas spleen has fine ecotexture. The capsule may appear as very fine echogenic line, or it may not be visible at all. And splenic vessels, they appear as elongated anechoic structures on longitudinal sections and round to oval anechoic structures on cross sections. So this is the spleen scanned through 10th intercostal space, that is almost in the middle of the uh, intercostal space. You can see this is the spleen. The capsule is not visible. This is the abdominal wall. This is the splenic vessel in longitudinal section, and this is the ruminal wall, which is medial to the spleen, and it appears thick echogenic semicircular line. So abnormalities, as I told, there are no specific conditions that can be diagnosed by ultrasonography in case of bovines. However, you may find focal or diffuse abnormalities which may have normal, increased, or decreased echogenicity. There are numerous conditions which cause splenomegaly, and there are numerous conditions which produce focal disease condition of the spleen. But for their confirmation, they require aspiration or biopsy for histopathology. The rumen is imaged in the region of left costal part of the abdominal wall or entire abdominal wall, except the areas where I have specified, where we can scan reticulum and omesum. In rest of the left abdominal wall, you can scan the rumen either through the intercostal spaces or through the left paralumbar fossa or the ventral abdominal wall. The ruminal interior will have three type of contents. The proximal 1/3 part contains gas, that is dorsal gas cap. The middle part contains the echogenic ingesta, and the ventral most part contains the fluid. So you can distinguish between the gas cap, dorsal gas cap, which because of reverberations will not allow the ultrasound to pass deeper, whereas the ingesta will appear as echogenic and fluid will appear as hypoechogenic. However, it will not always be possible to distinguish between the middle portion containing the ingesta and ventral portion containing the fluid. They may appear similar and may have similar echogenicity. These are the two pictures showing the scanning through the 10th and 12th intercostal spaces, almost in the middle of the abdominal wall. This picture I have shown you earlier, you can see the spleen, and medial to the spleen is the rumen, which appears as semicircular echogenic line, thick echogenic line. Whereas in this picture, you can see the ruminal wall is thick echogenic line, but it is indented medially. This indicates that this is the longitudinal groove, this is the dorsal sac of the rumen, and this is the ventral sac of the rumen. This is the dorsal side, this is the ventral side. Whenever you scan through intercostal spaces, you always keep the transducer in such a way that it points dorso-ventrally. So this will be the dorsal and this will be the ventral. When you scan in the middle of the 12th intercostal space, you will find the longitudinal groove. If you scan proximal to this longitudinal groove, you will find spleen there. And if you scan ventral to the longitudinal groove, you will find only the semicircular line, echogenic line of the rumen, because in ventrally the rumen will be in direct contact with the abdominal wall. In this picture, in this video, you see the scanning through 10th intercostal space. This is the liver and this is the rumen. You can also see reverberations from the gas in the rumen. This is the video through 12th intercostal space at the level of longitudinal groove. Here you see, this is the dorsal sac here, this is the ventral sac, and this is the longitudinal groove, and rumen will be contracting. Now this is contraction of the rumen. The other conditions which can be diagnosed by using ultrasonography are ascites. Ascites is nothing but accumulation of fluid in the abdominal cavity, and fluid will have varied appearance from anechoic to hypoechoic. This can be, ascites can be non-inflammatory. In case of non-inflammatory ascites, you will only find the fluid which will be anechoic or hypoechoic. Whereas if you find anechoic to hypoechoic fluid along with interlacing echogenic patterns, echogenic bands of fibrin which are floating in the fluid, or you find echogenic fibrinous deposits on the perireticular area, peritoneum, or other internal organs, or you find multiple fluid filled or pus filled cavities in the peritoneal cavity, it indicates inflammatory ascites. So by using ultrasonography, you can to some extent distinguish between inflammatory and non-inflammatory ascites. However, confirmation will require aspiration of the fluid under ultrasound guidance and its examination. Now, urinary tract. In case of urinary tract, the indications are almost same as in case of small animals. However, here the examination of urinary tract is not as straightforward as in case of small animals. The left kidney, left ureter, urinary bladder, and pelvic urethra, they are scanned transrectally because they can be scanned transabdominally through the intertransverse processes of the lumbar area with difficulty. So they are scanned transrectally with linear transducer. Whereas the right kidney and right ureter, they can be scanned from right paralumbar fossa, or they can also be scanned from the spaces between the transverse processes of the lumbar vertebrae. In case of calves, urinary bladder can be scanned through left or right paramedian site close to the pelvic inlet. And in case of penile urethra, percutaneous ultrasonography can be performed, but in that case, you will require a transducer which has very high frequencies, maybe 7.5, 10, or 12.5, because it is very superficial structure. In this picture, you can see the kidney has been scanned through the L2 and L3 transverse processes through the space between L2 and L3, and kidney appears unlike the kidney of canines. You cannot distinguish between medulla and the cortex. They are not distinguishable on ultrasonography. You see the uh, renal sinus in the center, and anechoic, the anechoic structures, they are the renal pyramids. In case of calves, as I told you that the urinary bladder can be scanned through left or right paramedian site close to the pelvic inlet. You can see in this case, this is the intact urinary bladder which has produced acoustic enhancement. Since the bladder is distended with the urine, you can scan it with 5 megahertz transducer also. In this case, the bladder has ruptured. You can find free fluid in the peritoneal cavity, and the structures cannot be identified, but they are freely floating in the peritoneal fluid, that is urine. So this indicates ruptured urine. And this is the scan of the penile urethra of a calf, male calf. Since it is very superficial, it has been scanned with 8.5 megahertz linear transducer. And in this, you find this is the distended part of the urethra, that is the part caudal to the obstruction. This is the obstruction. Now you can ask, if this is the obstruction which is usually from the calculi, why there is no acoustic shadowing? The acoustic shadowing usually is not seen in case of cows, because cows, sheep, or goat, because usually these type of obstructions, they are more consisting of organic material than the mineralized material, so they may not produce acoustic shadowing. So these are the conditions which can be diagnosed by ultrasonography in case of the calves using ultrasonography. Uh, there are still many conditions. For example, uh, you can scan ovaries, oviducts, uterus, uh, etc. through transrectal ultrasonography, or you can scan the uterus through transabdominal ultrasonography for detection of pregnancy, for detection of ovarian abnormalities like cysts, tumors of the ovaries. However, I have not discussed those conditions here because those normally are dealt by gynecologists. So thank you very much.